So it's my pleasure to invite Dr. SAJJAD Fazili, who is a leading surgeon from Jammu and Kashmir, who is the director of FAZILI Eye Care Center, Kashmir, who is also president of Kashmir Ophthalmic Society. We all know he is a prolific surgeon, and he always presents challenging cases in all the conferences all over India. It's great to have you, Dr. Fazili. Can you start your screen sharing? Yeah. We can't hear you, Dr. Fazili.
Dr. Fazili, you need to stop and then enable the show sound. Can you just stop? Dr. Sajjad? Just stop share. Dr. Sajjad?
Yeah.
Now enable sound before you share, sir.
That was a good video of yours, Dr. Fazili. We need to see it.
Yeah. Share. I'm trying to share. Can you hear me now?
No, we can hear you.
now. Yes.
So just click on the share screen once.
Yeah.
And on the bottom there is
No, you have to have your video open. Your the video which you're going to play. Yeah.
Yeah.
Yes.
We can see it now.
You can
Yeah,
hear
we can see it now. Yes, you can play it.
Yes.
Okay. So whenever we're talking about pseudoexfoliation, you can
No,
hear
just no, we can hear you, but the video is yet to it's playing.
yeah.
Yes, go ahead.
Perfect.
Go ahead. Perfect.
So talking about pseudoexfoliation means that you have to raise your antenna for potential problems during surgery. Despite the surgeon's best efforts, weak zonules may not be noticed until after the surgery has begun. You see here, I'm showing you a case with pseudoexfoliation. One of the problems is not there. It's not a small pupil, but as the air bubble goes in, watch the lens. Every time you go in and out, watch the lens and watch whether there are any unusual changes in the movement of the lens. When you don't have radial tension from intact zonules to pull against, the rhexis can always be an issue. The start has to be visualized, the back has to be seen whether there is any problem there. Here it's proceeding nicely, but it can always behave very strangely or start shooting out. Here I'm keeping it almost parallel to the pupillary margin. I generally put capsular hooks if there's an issue even before. Again, hydro dissection, wash the bag, watch its movements. And once you're trying to you're trying to rotate it, you can see that this bag is not very, very stable. So you have to do this gently. You cannot be very aggressive. You can see I've already noticed that you bring down the bottle height, bring down the irrigation, and you go. And chopping is perhaps the best technique. Puts least amount of pressure on the zonules. Now initiated a crack, reasonably good. I don't want to rotate this bag too much. I'm just trying to hold this here, and then suddenly I see that the zonules on this side are suspect, and now I'm thinking that all zonules are suspect. So what I'm going to do is put capsular hooks. And capsular hooks, by virtue of their shape and size, support the bag better than the iris hooks, since they support the equator, and the blunt tips, the tips are blunted so that they don't injure the bag. The capsule does not get torn. But I have worked previously with iris hooks also, but iris hooks would always be needed to be combined with capsular tension rings, and they would never be able to support the equator. So now what we are doing is trying to bring all the supports, trying to err on the more cautious side. I could have started on one side. The capsular tension ring is going in. Now, this is very important that we know when to implant this. So it can be delayed, but when postponed, when positioned in the capsular bag, the ring exerts an outward force and that redistributes the tension within the bag. And then you have to bring down the bottle height further, work on lower parameters, literally make it slow motion. Because whatever zonules are left, where there is, we know now there's a weakness, whatever zonules are left, we want this to proceed slowly. And we want to do it at much lower parameters so that we do not actually still manage to, I've seen many a times a PC rent happening even when you're taking the last piece, because in spite of the CTR, there may be an issue. And then you do a cortical cleanup. It's obviously more difficult when you have implanted a CTR ring first. And then you implant a lens which is slowly unfolding and place it in the bag. Normally, at this point, I would first normally remove all the hooks and then remove the viscoelastic. Here I am removing some amount of viscoelastic, and then I am stromal hydrating the main port so that there's some viscoelastic left, not all of it is cleaned up, and I remove the, again, that is because when I go in with the fluid, there may be an issue and that I'm gonna lose the bag. At the end, I wash with irrigation only and hydrate all the side ports with this idea that even if some amount of viscoelastic, in spite of a pseudoexfoliation and the possibility of the IOP spiking, I might still get away with not having a bag which has fallen into the vitreous with aggressive irrigation. Thank you all for your kind attention.
Thank you, Dr.
Thank
Fazili.
you.
That was a extremely wonderful teaching video. With the number of capsular hooks you have placed and giving the anterior-posterior support, I actually wonder whether you could have even placed the CTR right at the end so that there is great ease in removing the cortex too, because that was a massive support you had provided all around. So
It's actually very surprising how pseudoexfoliation can actually behave. So if you have, this patient was a one-eyed patient, he had already lost the left eye to a less careful surgery. And then to my mind, placing a CTR should be as early as necessary, but as late as possible. So if you are trying to err on the safer side, then you would want to implant it earlier, especially if you're using capsular hooks and not iris hooks, which are usually available to most surgeons. But to my mind, another important thing is that if you are using, I agree with you, if you're using them late, every step, if you're confident, every step becomes easier, especially the cortical cleanup. Because cortical cleanup can get a little slow, a little dragged because of the capsular tension ring. I agree with that.
And again, in your particular case, placing a single piece lens was fine because till the end, the area of dialysis was not very obvious, but probably otherwise a 3-piece IOL could have been placed as an alternative for giving that extra support.
Yeah, I understand. You mean a segment?
Not a segment, just a 3-piece IOL instead of a single piece is just a thought.
Yeah.
Have been done instead.
A single piece IOL in the bag?
No, a single piece IOL is what you have placed in the bag.
No, sorry, a multi-piece in the bag?
In the bag, yeah.
Okay.
Could have been a thought. I want the opinion of the expert panel or anything more to discuss. He has very well discussed his case.
Yeah, I would like to come in, Chitra.
Yes.
Yeah, doctor has shown a beautiful case. It's a difficult case, and he has done a wonderful job. But I just wonder, since he's from Kashmir, in his ethnic population, what are the severities of this pseudoexfoliation at a later date? Because when we do pseudoexfoliation, and if it's of a advanced nature, and at the end of the surgery, you find everything to be, well settled. Now, these are the people who come back after 9 or 10 years with subluxation or sometimes a severe dislocation of a lens. So I just wanted him to share what's his experience with, such advanced pseudoexfoliations coming later on with some complications, Dr. Sajid?
Yeah, I don't know. I come from a place where pseudoexfoliation is very rampant.
Okay.
And to be very honest, the zonular laxity in pseudoexfoliation cases is one reason why many colleagues are referring cases to me. I have had a large series of these cases, and astonishingly, I have not seen more than around 5 or 6 of nucleus drops, or what we say a gross subluxation of the bag. Most probably because if you are very careful and aware, 2-3 things definitely happen after a cataract is removed in pseudoexfoliation. One is that the amount of pseudoexfoliation actually seems to reduce. Number 2 is that if there is no capsular contraction, active capsular contraction taking place, and if you are doing regular releasing YAG laser capsulotomies in the anterior capsule while you are following up, generally speaking, the capsular contraction is the reason why these cases might land up in dislocation, subluxation, eccentricity of the lens. But overall, cases well done, I have not experienced, it's a very insignificant ratio I'm talking about. I have not experienced, I've experienced 5. And that is in around 20 years of doing subluxation. But considering it as a very bad case, a very bad case scenario, and taking extra, like Dr. Chitra told me that you were using so many hooks. It was because I was erring on the other side. I was erring on the more cautious side. So I'm trying to save as many as zonules that are left. We know that pseudoexfoliation is also a progressive disease, but strangely, the zonular weakness seems to slow down a little bit. I've not actually encountered many. One of the reasons might be that a patient finally goes to some other doctor, finally for the follow-up, because they thought that they had gone to one doctor and he did not do a good job. But they are usually happy because after surgery, because they have been referred and they've had a good result, and that should make them happy. I personally feel
Congratulations, SAJJAD. Devan, I think it's a beautiful surgery, and your 20 years of experience of doing these cases stood out in the sense that it was so nicely handled, and even the elegant chopping. And I completely agree with the timing of your introduction of endocapsular ring, because though the capsular hooks give you anterior posterior support, you need circumferential support of the limited zonules that are available. And this cataract hardly had any cortex, so it was not really a challenge, and you handled it beautifully. But just to echo what the point my friend was trying to make, I think it was an extremely loose bag, and Suhas was trying to make extremely loose bag, and that's the reason you had to put 5 or 6 capsular hooks. And as you also mentioned, it's a progressive zonulopathy. Though your experience has not shown you that, most often these cases tend to subluxate the entire bag lens complex over time. And in these cases, putting in a CTS or a Sionis ring, especially nowadays, the trend is to put 2 CTS in diametrically opposite to each other, so that you sort of tether it to the sclera, and even in the future with the lens in the bag, there's no tendency for subluxation. The other point that could be made was the 3-piece lens in the bag was talked about, but the greater tendency now is to put the lens, a 3-piece lens in the sulcus and create an optic capture in the bag. And that is again something which is supposed to give extreme stability to the capsular bag. I think it's tremendous surgery. I don't know whether I could have done the way you did it, but 2 things I would have differently is that I would have put in a CTS, especially considering the amount of support it needed for you to continue with the surgery, to tether the capsular bag to the sclera, and secondly, maybe use the 3-piece lens and in the sulcus with optic capture.
Yeah.
Thank you very much. Well discussed. So thanks, Dr. Fazili. Look forward to having you in more of our CMEs.